Hey everybody, thanks for joining. We'll give a few minutes for people to arrive. Jordan, let me know when we got a
All right.
few people on the call. Yep.
Yep. All right, we're going to go ahead and get started. So hello, everyone, and thanks for joining our webinar, Harnessing AI and How NLP and Terminologies Can Shape the Future of Rare Disease Care. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode, but we'll have a Q&A session at the end. So if you have any questions coming into this or during the presentation, just put them down in the Q&A button in your webinar console. We like to keep things interactive, so I'll be launching poll questions during this presentation. And today we have our Senior Vice President of Commercialization at IMO. His name is John Larson. And so without further ado, I'm going to pass it over to John.
Hey everybody, thanks Jordan. Thank you all for spending time on your hump day to spend some time with us. Today we're going to be talking a little bit casually around how natural language processing and particularly clinical interface terminologies, which is frankly what IMO has been doing for the last 25 years, can help organizations that are focused on rare disease care. To give you a little background about who's talking to you, I'm our Senior Vice President of Commercialization. So that's a opaque term. So what does that mean at IMO? It means that I'm responsible for helping make sure our products are aligned to our segments of the market that we want to add value to. Providers, health technology, payers, life science, and the public health department. I've been focused on healthcare technology for about 20 years. Much of that was in a consulting capacity where I worked with the academic medical center market, supporting their three-part mission of clinical care, academics, and the research side, and joined IMO about 4 years ago. I joined IMO even though I'd never really heard of the company after being in healthcare technology for 20 years. But when I got a call and asked to take an interview, I was surprised because IMO's been around for about 30 years, and we're embedded with almost every provider in the country, every health system, but about 4, and tens of thousands of physicians are using IMO every day. We're based here in Illinois, where I am in. I'm actually downtown Chicago on a rainy day. We're based here in Illinois, but we've been providing our clinical interface terminology to all of those health systems and physicians all across the country and really the English-speaking world. We're embedded in the NHS, within many countries in the Middle East, within Australia, New Zealand, and so on. Wherever English is used to document in the electronic health record, IMO's content is present. I mean, I'm kind of understating our presence in the market. About 4,500 hospitals use IMO every day. That reflects about 89% of the clinicians in the United States. 30 years we've been in business, and as I mentioned, about 750,000 physicians are pinging IMO's content. You can think of IMO's content as, I like to describe it as kind of a dictionary that physicians ping to find the right information. We get pinged 6 billion times a year by clinicians all over the world. And the reason we get pinged that many times is because that we are embedded within the electronic health record. IMO's content, and I'll kind of give you a description of what that means in a second, is present within the major electronic health records, both at the acute level and at the ambulatory level. The reason that we are present there is that we really gain the trust of the electronic health records and their users because we solve two problems at the same time, two problems that are really critical in the US healthcare in particular. Physicians who learn their craft in residency and fellowship want to be able to document in the electronic health record in a way that they learned, in the way that they learned in their training, in the way that they speak to their peers, in the way that they want to express the true clinical condition of that patient. But on the back end of a health system, they need to have that information that the clinician put into the electronic health record coded in a way that drives billing and analytics for that health system downstream from that moment where the care is being documented. IMOs essentially supports both of those use cases at the same time with our clinical interface terminology. And that's why we've really gained the trust of those EHRs and those physicians and those health systems, is that we are supporting those clinicians to capture that clinical intent of that patient and still providing all of the necessary coding that drives billing and analytics downstream. So that's what's got us that market share today, but it also unlocks a lot of opportunity as now that clinical data is being aggregated at scale. And so now you know a little bit more about us. I'm going to spend the majority of the time talking about what does that enable as you start running analytics and trying to find more and more accurate patient cohorts. But I do have one question for the group. And since this group is made up of really not a lot of non-clinicians and non-EHR day-to-day users, I wanted to ask the question about, are you leveraging electronic health record data around patient diagnosis, around the procedures that are documented in the electronic health record to really find more and more rare patients where maybe billing codes are not sufficient to identify them? So I'll pause and let you guys process this question first. Jordan, will you let me know when we get a meaningful group in here?
Yep. Yes. Just a few more seconds and then I'll close out. So John, it looks like we're kind of like 55% said no and about 45 said yes. And now we're tied.
Okay. I mean, it makes sense. A lot of this EHR data is just now getting aggregated at scale. It's been locked within much of the individual health systems, and now through interoperability requirements from the federal government and more health systems working to aggregate their own data at scale, hopefully this data is becoming more and more valuable. To make kind of the reason we're having this conversation more relevant, I wanted to give a little more information on what that is that IMO is providing in the EHR to those clinicians. And it's really our clinical interface terminology. This is the content. When I talk about those 6 billion pings, this is what we're enabling physicians and other clinicians to look at to say, yes, this describes my patient. And this is what we've been curating for the last 30 years and are constantly keeping updated for those clinicians to help them when they're documenting. What you're showing here is a reflection of how IMO's content is structured and maintained. IMO is a concept-based architecture, meaning we have clinical concepts that accurately describe diagnosis, for example, procedures. We have clinical concepts that relate to labs, relate to medications that we aggregate up. But you can see here in this example, we have the clinical concept of a breast cancer metastasized to pelvis. But over our 30 years, we have been getting feedback from clinicians, watching how they document, and we have hundreds to millions of synonymous terms that relate to that clinical concept, allowing physicians to express that clinical concept in their own style, in their own regional dialect, in their own way that they learned in residency and fellowship. So while the concept is still accurate, we allow those clinicians to capture that within the EHR in that structured manner, reflecting their own language. We still map that back to that concept And we also then map that concept to all of the code sets that accurately reflect breast cancer metastasized to pelvis. So again, we're solving kind of the two things that I mentioned at the beginning. We're allowing the physicians to express him, her, themselves correctly in the way that they want to, but we're maintaining all of that mapping within the electronic health record so that data can flow downstream. And that mapping is extremely important, and the way that we approach that is unique in healthcare today as well. So breast cancer metastasized to pelvis allows us, we map that to the multiple ICD-10 codes that reflect that clinical condition. We then take a step back and say, well, now let's map that to SNOMED. There is no crosswalking here. We're doing that independently so that we can get the most accurate map to each regulatory code set. What that means is you can really think about this IMO ID, this breast cancer metastasized to pelvis, as your Rosetta Stone. If you know that term, that breast cancer metastasized to pelvis, or you have that IMO ID present within a data asset, you can map that to all of the regulatory codes that may define the inclusion-exclusion criteria for your cohort. And IMO is maintaining that mapping. So that's one reason the EHRs has trusted us over these years, is that we provide that accurate mapping, releasing updates annually, at least 13 times a year. And we're also able to stay ahead of the mapping bodies themselves. So we get feedback from all of those physicians that say, man, I would rather describe this clinical condition slightly differently. So we add 50 to 60,000 terms a year and then maintain those mappings as appropriate as well. Now, we're not the only organization in the world that does clinical interface terminology, but the way I kind of describe our differentiation is really across two axes. One is IMO as a robust team that maintains that mapping, and that our mapping approach, where we say, what is the best ICD-10, what is the best SNOMED, not trying to do crosswalks, is unique. But really for this conversation, it's more about the depth of our clinical interface terminology. We are a magnitude more specific than certainly ICD-10, than even SNOMED, allowing us to express laterality, allowing us to express phenotype in a much more specific way. And this is what gets me excited about why our terminology can help organizations that are looking for more specific patient cohorts or more rare disease patients. So IMO terminology, which again is stored within the EHR at the individual patient level, it's helping those physicians capture it. So when a physician says breast cancer metastasized to pelvis, that IMO ID is stored at that local patient level. It can be highly specific. So hopefully that gives you a sense of kind of our underlying interface terminology and sets the stage of how that can help with that more accurate cohorting. But we did talk about NLP, so I wanted to make sure that we talk about how we support the natural language processing. Been talking a lot about structured data, a visit, diagnosis, or a procedure. But as you start to mine the unstructured data, having that clinical interface terminology as a resource for entity recognition or and then resolution to all of those maps that I mentioned, that's where clinical interface terminology can be a differentiator as well. IMO recognized that. We were fortunate enough earlier this year to bring on a company called Malax Technologies. This is an organization based out of the Texas Medical Center that has been working within the academic medical center space, particularly on the research, supporting research for the last 10 years. They have 650 academic centers and individual end users that are using their NLP today. The reason we brought them into the IMO fold is really what I said, is we're going to apply that clinical interface terminology to support the natural language processing, helping to do better entity recognition within the unstructured text, using the knowledge of those 6 billion pings a year of how physicians express the pre-coordinated clinical condition of, or the post-coordinated clinical conditions of those patients. We did some work with the leading children's hospital where we focused on HADS disease, very rare disease, but where we went through millions of written notes within that health system to identify patients that could not be identified using billing codes. But using that NLP, we could identify those patients that were both diagnosed, but also then are leading indicators for developing HADS. So it really matters how specific you want to be. IMO's terminology stored within the EHR can be translated down to a large data asset to enable much more accurate cohorting. Cohorting where you can say, what are patients like me, who were treated like me and had outcomes like me? To make those cohorts accurate, you really need terminology at every level. And then once you employ the natural language processing, you can start including things like the patient recorded notes, and then start looking at even temporality within that to help identify a much more accurate cohort. So I think we're going to do one more poll question here. I mean, one of the concerns that I wanted to get feedback from the group is the data assets you're using today, especially as you look for more specific patient cohorts. Are you finding that one of the biggest risks is that you're just identifying too many false positives, requiring a lot more effort and work to find the right patients, even after you run the analytic cohort?
We have a few more seconds, John. All right, go ahead and close it. So it looks like majority are saying yes.
I mean, that would make sense. I would hope if you were on the call today, that would be the challenge statement you were hoping to resolve. And I think that makes sense. I mean, just to give you some example of how we could help that, or how the terminology could help that. As you think about applying that terminology, a terminology that is as specific as IMO strives to be, you can really increase your value set capture. So we're going to be able to increase the sensitivity by finding more patients, by accurately describing your inclusion-exclusion criteria. But you can also flex up on the specificity side. For example, the IMO terminology provides 100% identification. We have terms that identify all NIH rare diseases. And that's in structured data, meaning that that was captured via IMO terminology as a visit diagnosis. Compare that to SNOMED or even ICD-10, which has a lower prevalence of that specificity, generating many of those false positives that you would have to dig into potentially the unstructured data to find and weed out. And again, that's a reason why we're present in the electronic health record. Clinicians want to express that patient's condition at the accuracy level they know is appropriate for their peers and for themselves. So that's why IMO terminology has gotten that market share at the point of care. Just to make this even more real, we did a work with a large manufacturer, pharma manufacturer, where we looked at a large data asset, electronic health record data asset. Their inclusion-exclusion criteria for the value set or the cohort, using regulatory codes for this rare disease, they found about 100,000 patients that they would have to investigate further. Just using the IMO terminology in your inclusion-exclusion criteria, we found 108 patients immediately where that terminology was present in structured data captured within the EHR by the clinician. And for most of us on this call, I mean, we know that 108 may be all that you need to go after and begin that next phase of the drug pipeline. So that false positive component really rings true for me. And this is kind of one good example where using the IMO terminology as a potential way to develop your cohort could eliminate a lot of manual review down the path. One last question, and then we'll turn it over for a few. I mean, I recognize this is a little simplistic, but just kind of understanding, knowing that there's a lot of competitors out there around finding data sets for your eyes and for your team's eyes. What really drives your evaluation when looking at a data asset to subscribe to or purchase?
There are a few more seconds. All right, we are going to go ahead and close it out. So it looks like specificity of data and kind of longitudinal patient records are the winning.
Yeah, that would make sense as we kind of move into some of the more specific cohorts. Well, I mean, hopefully you got a sense of that's kind of why IMO's sponsoring this conversation. I mean, we want to be able to increase the specificity of any data asset you have by leveraging what was documented using the terminology within the EHR at the point of care. And then using that terminology in the patient note, we have shown, particularly with our work within the large children's hospital, that we can help identify kind of a longitudinal patient record with that same level of specificity all down the path. So hopefully you're seeing a reason why we're hoping to engage this group in the conversation today. So I don't want to bore you guys, so I kind of summarize it across a couple axes here. We're hoping to actually help speed to identification. That's one of the value statements we want to bring to the market and to really the organizations that are focusing on these challenging patients. Help them identify them faster with less effort. So reducing the effort and the personnel necessary to review false positives. I mean, those are kind of combined together. Now, where IMO can help, I mean, where patient recruitment is challenging within these rare disease patients, remember that data is stored within the EHR. How can IMO work to help unlock that and find that? Where dirty or incomplete real-world data sets have been aggregated, particularly both in the text, structured text and the unstructured text, can IMO provide some appropriate enrichment on the standard codes, making sure all the SNOMED and ICD-10 and CPT and HCPCS are on that, but also bringing along that data that was captured, that specificity that was captured in the EHR into those real-world data sets. And then again, unlocking the longitudinality of a patient within the unstructured notes. And that requires understanding, IMO's understanding of the temporality of when those things occurred, along with that deep clinical description of that patient. Oh, that went fast. All right, that was all the content I had. We do have some time for some Q&A, and it looks like there's one that came in right now. So I'm going to stop sharing my screen and then open it up for the Q&A here. All right. Jordan, can you help me on the Q&A here?
Yeah, John, I know you had some questions that came in before.
Yeah. Well, there's a good question on here, and I'll answer this one around. I mean, specificity, we talk about rare disease here, but is not related to that. I mean, the question that came in was around risk adjustment and acuity adjustment of patients. Also, a kind of a use case that we focus on. But one that I know that I had gotten in advance of this through LinkedIn, so thanks for the person that sent this, was, I mean, what is IMO's, sounds like IMO's focused on the electronic health record. What about some of IMO's supporting what I call the large data aggregators, the organizations that are pulling all that data together and packaging that in terms of a subscription or a purchase we do provide support there. And to be frank, it's a little bit of a chicken and an egg. So part of this is helping organizations understand that there's a structured terminology that's available within the EHR that can support that level of specificity so that you can begin asking for it, right? I'm hoping that people are doing that, this rare disease investigation, are saying, man, I would really like that. Company X, can you add that into your interoperability request so that it's present within your data asset? So we're hoping to kind of inform on the value side here that you can find more specific patients. You can really identify those rare disease patients within structured data, but let's bring that data out of the EHR then into a large data aggregator. Looks like another one just came in around the NLP function and essentially kind of accuracy. So I always find this one a tough one to answer because accuracy is really in the eye of the beholder here. But what we have seen working with a number of clients who are looking at unstructured data is that the entity recognition, particularly post-coordinated entity recognition around diagnoses, is much more accurate using IMO's terminology, which makes sense, right? Helping an NLP model using the terminology that physicians use every day, 6 billion times a year, should be able to help you find when they not only put it in a structured fashion, but type it into a clinical note or narrative. So I think those are two pretty common, that's a pretty common use case that people are looking forward to and saying, man, I really want my NLP accuracy to be much higher. And when you get into more rare diseases, that accuracy needs to be even higher levels of performance. And that's where a clinical interface terminology as a kind of a training stat can really improve the NLP performance. Oh, great question. Somebody just asked about large language models. I was hoping I didn't have to talk about AI or large language models in this call, just because it's sucking up most of the of the air today. But the answer is, the question was, are you using any of the large language models coordinated with your terminology system? Yep. I need to be careful about how we talk about this. I mean, everybody's kind of focused on this, but I think the way I'll posit it is we are evaluating all of the advancements over the last couple of years. But what differentiates IMO is really that we have a corpus of content that has been tuned over the last 30 years, is constantly getting feedback from clinicians, and an editorial policy that helps us evaluate deviations in the way that clinical concepts are described. So we are using large language models, and we think there's some support and some excitement that we can bring to that market using what we have curated over the last couple of decades. Nice. Well, Jordan, I think I don't see a lot more come in.
Yeah.
Right.
All right, so we're going to go ahead and close out today. Thanks so much, John, and thank you, everyone, for those who tuned in for your time. If you have any questions for anything IMO related, you can contact our sales team at sales@imohealth.com or visit our website, imohealth.com. And thank you so much for attending, and I hope you have a great rest of your day.
Thanks, everybody. Talk to you all soon.